Hi guys, hey family, hi friends. In this video I want us to talk about a patient that we did yesterday in the ophthalmology theater. So let's just go over the sequence of events, what happened. Once more, the reason why I do this, I want you guys to see the different anesthetic approach for different operations. That's why we do ops. That's why we do neurosurgery. Done obstetrics, neurosurgery. We are gonna do urology, and we've done 3 videos. It's just that I can't remember the third one, but we have already done 3 videos. So this is our fourth one. So ophthalmology. So this case was that of 56-year-old female. She had a corneal lacceration, and the plan was to repair that. And she had no comorbidities. So apparently this lady, she went to the forest to collect some wood, and then unfortunately a piece of wood got stuck into her eye, left eye. That's how it got damaged. So anyway, so the approach for this case was, so the patient came into theater. We had already decided what we're gonna do. So she came in, we transferred her from the stretcher onto the table, like we always do it. Attach monitors. And the monitors that we attached, NIPP, sets probe, ECG, leads. We had already prepared our drugs, right? And then we inserted an IV line. Well, she already had an IV line, just that we had to change. They had used a small caliber, so we changed to a bigger caliber. And then we pre-oxygenated. Now there's a video that I've just done now, that I've just uploaded, where the title is like, when do you decide to use when do you decide to intubate, and when do you decide to do an LMA? There are patients that are under AGA that are intubated. Then there are those that are still under AGA but they're not intubated. Instead, an LMA is inserted. So please go and check that video. That's why I explain it nicely, which patients needs intubation, which ones need LMA. So we pre-oxygenated. After that, we gave fentanyl. Then we gave propofol, and then we inserted the LMA. 7, confirmed. Placement. 8, we secured. Number 9, we connected the patient to the vent machine, and then we maintained sevoflurane. Guys, it's gonna help you a lot to look at these cases that I've uploaded. Just watch and look at each and every step and try to make sense of each and every step so that you can appreciate the differences and it's easy for you to answer questions. So let's look at this case. So if you can check here, this patient was gonna be done a corneal lacceration repair. So we had decided that she needs a general anesthesia. Right? That's what we decided. And then she was fasted. So she had no risk for aspiration. Because she had no risk of aspiration, we were not required, or it was not, we're not compelled to intubate her. So we opted for an LMA. If she had a risk for aspiration, we were not, even though she's an elective, we were not gonna put an LMA, we were gonna intubate her. But because she was fasted, we put an LMA on her. Now, because we inserted an LMA, when you insert an LMA, you don't have to give a muscle relaxant to facilitate the intubation. Muscle relaxant. So we didn't give any muscle relaxant here, as you can see. And also, because she had no risk for aspiration, we did not do a rapid sequence. So those are the important things that you must check here. So those are the important points to take note of. And another thing is that, look at this. Sevoflurane is usually used for induction and to maintain anesthesia in the pediatric population because of its properties. And one of them is that it doesn't irritate, or it's less irritating to the airway compared to the other volatiles. But in this case, this patient, normally on a child, on an adult, we would use isoflurane because we try to reserve sevoflurane for the pediatric population, and also sevo apparently is very, very expensive. But we continued up until the operation was done using sevoflurane, and the reason for that is isoflurane is irritating to the airway and can cause a patient to have secretions. And remember, you've got an LMA, which is not the best. It's not the best option in terms of airway protection. So we know it's inferior to intubation. So you have an airway that is not like secured 100%. And now you're gonna irritate it and start having problems there. So that's why we didn't use isoflurane there. We continued with sevoflurane. So guys, if I was a student, I would have loved to be taught anesthesia this way, because when you go to theater, as you stand there as a student, this is what they're gonna be doing. They'll put the patient, they'll take the patient off, take the patient off the stretcher onto the table. They will attach monitors. Someone else will be making sure the IV line is going, and then the drugs are already prepared. And then you see a doctor now, you see one person holding a mask over a patient, ventilating the, oxygenating the patient. And then the next thing, someone else is just pushing drugs. These are drugs that they push in there. And now you see someone pushing in LMA. So these are things that are done. So remember, we've spoken about pre-oxygenation. Pre-oxygenation is all about replacing the nitrogen in the lungs, making sure that we've got a lot of oxygen in the lungs. So they call it a nitrogen wash out and oxygen wash in. So and it's done, give it, so it's 100% oxygen. Some people say you do that for 3 to 5 minutes, and this was our induction agent. This was our induction agent, and induction agent, and oh, there goes my battery. Okay guys, we're gonna talk about another case though. I think we have finished this one anyway. Thank you.